In addition to focusing on developing new drugs with novel mechanisms of action, let's prevent infection. So if you prevent infection, you don't need the antibiotic and you don't create the pressure for the development of resistance.
Hi, Prof.
Hi.
Good afternoon, and thank you so much for doing this interview at the International Congress on Infectious Diseases. I've read so much about your work. You've been doing this for years. You're on the SAGE Advisory Working Group with the WHO, and you have done quite a bit of research on AMR. Both for South Africa, you've supported countries with developing AMR national action plans. So given the unique challenges that we have in Africa, what would you say are some of the key ways that we could strengthen surveillance systems and help tackle the huge public health challenge that AMR is?
So thank you very much for the opportunity. It's a pleasure to be here, and it's a pleasure to be able to speak on behalf of Africa and our unique challenges. So the two key indicators for success for me in terms of mitigating AMR in Africa would be political championship and domestic funding. When it comes to political championship, we need the ministers of health, agri-food and the environment to come together to collaboratively work on developing and implementing national action plans on antimicrobial resistance, because antimicrobial resistance is so much more than a human health issue. It is detrimental to the health of humans, animals and plants. It causes toxicity to the environment. It affects food security and food safety. And it really has an impact on the economies of the country. So we need the political leaders to come together and really motivate and champion for AMR. The second aspect is the funding aspect, and we will always be constrained. Every health system will be constrained when it comes to funding. And in Africa, we have so many health priorities that it becomes really difficult for us to choose one above the other. There's no new money, unfortunately. And so what we have to be is strategic about using existing funding that is related to AMR in some way to be able to also answer the AMR challenges. So if we think about universal health coverage, if we think about the national drug policy, if we think about standard treatment guidelines and the essential medicines list, all of these have funding associated with them. And that funding could also answer some of the AMR challenges. When we think about the highest burden of disease, infectious diseases in Africa, we think about HIV, TB, and malaria, the big three. All of these are vertical programs, and they already have very strong surveillance infrastructure. So why don't we piggyback on that and also do some kind of surveillance for AMR? We all test our water quality. We have wastewater surveillance for polio. We've got wastewater surveillance for COVID-19. What is stopping us from filling up one extra bottle to also ascertain what the AMR problems and the concerns are? So we have different pots of money that can also address the AMR challenges. And I spoke about some of the programs and systems that are there in human health that can also be leveraged for AMR. Similarly, we have programs in animal health, food safety, food security, biosecurity, port health. And in terms of the environment, we test our water quality. We have wastewater treatment plants that we have to have the efficiency tested of. So all of these things can also be used to address the AMR challenges. I want to specifically speak to the wastewater-based surveillance of polio that we conduct in our countries, as well as the wastewater-based surveillance of COVID-19. And this also gives us an opportunity to look at monitoring antimicrobial resistance. This is going to give us an idea of what the population level challenge is. So it won't tell you that this antibiotic will work for this patient, but it will tell you that you have increasing or decreasing levels of antimicrobial resistance. And if a hospital is using a particular antimicrobial class, then it should perhaps consider changing it if we are seeing escalating resistance to that particular antibiotic. So yes, we do have challenges, but we also have several programs in place that can be leveraged to also address AMR in Africa.
Thank you so much for that. You're right. In terms of leveraging the existing funding, for example, Nigeria has a new action plan on AMR, and it's costed, and it's about $77 million. When I first saw that, my first thought was, how are we going to get this money? How do you get the money to actually implement the plan and then measure progress over time? So what you said about leveraging existing programs, I think that's really spot on. But can you speak a bit to how countries learn from each other? How can we share data and resources?
Sure. So besides the countries having to find their own domestic funding to be able to address AMR, we do have external funding. So you're well aware the Fleming Fund has invested a lot of money in surveillance systems in low and middle income countries. They've generated data, and there is an effort to share this data by regional programs of the Fleming Fund. For example, the Measuring Antimicrobial Resistance and Use program, or the MAP program in Africa. The idea is firstly is to make sure that the data that we generate is quality assured data, so that we have robust representative data that is giving us a correct picture of AMR in our countries. And this really has to deal with quality assurance and making sure that the data is quality assured and it's giving a true representation of the work. You would have seen a number of publications that speak about the concerns related to AMR data in Africa. The Fleming Fund MAP project that I spoke about looked at some 800,000 records from 205 laboratories and found that only 1.3% of laboratories actually did bacteriology. And of those, most of them did less than 1,000 antimicrobial susceptibility tests. And so the data that we're getting out of Africa is very skewed. So first of all, we have to make sure that we get quality data, and then we have to find ways in which they can be standardized and so comparable across countries. Now, the GLASS platform, the Global Antimicrobial Resistance and Use platform, is a good platform where everything goes into a central database. But all the steps before that platform, in terms of the sampling framework, the quality assurance, the type of laboratory processes, etc., also have to be harmonized and standardized. So we're comparing like with like. The Fleming Fund has invested money, it's investing in people, building the capacity, investing in infrastructure and systems. The true challenge is then for the countries to run with it afterwards and to upscale and include more labs in the surveillance process. So we have external funding. It's going to end. Ultimately, it will. We have to look up to domestic funding to be able to pick up the slack. But the third way in which we can deal with it is to have twinning. So can we have twinning between South-South countries as well as North-South countries, where there's mutual learning and mutual reciprocity in terms of how surveillance should be conducted and how we can best share data. There's always a concern about sharing patient data and highlighting problematic areas which then have an impact on tourism, especially if it's medical tourism, etc. So it has to be a very considered and nuanced way in which data is shared and used, so that it does not disadvantage the country in any way.
Right, absolutely. And you've done quite a bit of research on molecular epidemiology, genomic surveillance. What would you say are the key innovative lessons that have come out of those studies, and how can they be applied across Africa?
Sure. So we always think about antimicrobial resistance as a quintessential One Health issue, because it exists and it's transmitted between humans, animals, plants, and the environment. So my work at the University of KwaZulu-Natal in Durban, South Africa, focuses on AMR and One Health. And what we've shown is that we've shown similar bacterial species, we've shown similar antimicrobial resistance genes, and we've shown similar mobile genetic elements that exists in food animals, in humans, in water and soil environments, plants, etc. But what we haven't shown is what are the transmission dynamics and the directionality. Do they go from humans to animals, or animals to humans, or environment to humans and animals? And this is what we're focusing on now, so we know exactly where the hotspots are and where we can break the chain of contagion so it doesn't spread anymore. So that question has not yet been answered, and we're working to answer that at the UKZN. We're looking at it in terms of whole genome sequencing and bioinformatics, as well as metagenomic sequencing, and hopefully watch this space, we'll have some answers for you in the next 6 months to a year.
Well, that sounds amazing. In terms of this sort of research and scalability across Africa, what are your thoughts on capacities within the continent?
So I think that the priority should be simple microbial culture and susceptibility testing that is easy to accomplish. It's relatively less expensive than the genomic aspects of it, and it gives us the answer that will allow us to optimize the treatment of people that are ill. So I would like to, for us, in the first instance, to focus on the phenotypic aspects, simple laboratory capability to do microbial culture and susceptibility testing of the most common bacterial pathogens. Genomic surveillance gives you lots more information in terms of what types of resistance genes there are, where they are carried, are they mobilized, are they co-carried with other resistances, etc. But this is, for me at the moment, this is a nice to have. So let's focus on getting an idea of what the nature and extent of AMR is, to be able to treat patients correctly, and then we will go into the genomic capabilities as well. Again, the Fleming Fund is funding a lot of the genomic aspects as well, and we have built capacity. We have centers of excellence in almost all African countries, and we now need to learn from each other, share all of our expertise, what has worked, what hasn't worked, and learn from each other to make sure that we optimize our systems, both in the phenotypic aspects as well as the genomic aspects.
Yeah, thank you so much. And South Africa has been at the forefront of, the AMR fight. You had the technical working group on this. What are the key lessons from South Africa that other countries can take up?
So South Africa has a national action plan. It started up, the first national action plan was published in 2014. That was very human health focused. We then brought in the animal health sector, and then we had an updated national action plan. Our current action plan expires at the end of this year, and we're in the process of developing another one. So maybe I'd like to just speak to the progress in terms of the 5 strategic objectives of the Global Action Plan. So strategic objective 1 speaks about education and awareness. And in terms of awareness, we started up the Antibiotic Guardian program, where healthcare professionals, civil society, farmers, food producers, veterinarians, all of them expressed an intention to address AMR in their own personal capacities. It was a voluntary, I am an antibiotic guardian. It was sort of a predetermined set of commitments that people signed up to. So that was Antibiotic Guardian, based on the UK Antibiotic Guardian program. In terms of education, I can give you the perspective of the pharmacy sector. Our pharmacy council got together all of the universities that are offering pharmacy, and we got together to share what we were covering when it came to antimicrobial resistance, antimicrobial stewardship, treatment optimization, etc. And this was then included into the scopes of practice, and universities were asked to amend the curricula to ensure that AMR was upfront and prominently included in the pharmacy curriculum. So that was the strategic objective 1 on awareness and education. In terms of strategic objective 2, which is surveillance and research, the surveillance program was a voluntary program that was started up by the public and private laboratories under the auspices of the South African Society of Clinical Microbiology, which is now changed, and I think it's now the Federation of Infectious Diseases Societies of South Africa. And basically, it is lab-based surveillance where we analyzed all of the isolates that were processed in the public and the private labs and came up with resistance rates to different bugs. We focused on bloodstream isolates and cerebrospinal fluid isolates, and on the escape pathogens. So the escape ones being the ones that escape the activity of antimicrobials. We then set up sentinel surveillance sites in the public sector where they were doing a little bit more in terms of getting patient data, etc. And all of this is managed by the Central Data Warehouse at the National Health Laboratory Services. And this data forms the basis of our surveillance reports. We also look at procurement data and ICVIA data to look at how antimicrobial use is being used. So we have, perhaps not representative, but some data on antimicrobial use and antimicrobial resistance in terms of surveillance. When it comes to research, we haven't as yet determined a AMR research priority agenda for South Africa. But we have very strong research groups in various universities that are looking at antimicrobial resistance in different ways. So in human health, animal health, One Health, water, soil, etc. So we've got discrete research projects going. The third one is infection prevention and control. And we developed our IPC policy and implementation plan during COVID-19. So it deals with how to prevent hospital-acquired infections, and I suppose COVID was the impetus to do this. We should have done a long time ago. So infection prevention control, equivalent to biosecurity in animal health, where we speak about vaccination, disinfection, things of that sort. So that's the third one. The fourth one is antimicrobial use. And I suppose our antimicrobial stewardship is the strongest, both in the private sector, where hospital groups have done great work on it, but also within the public sector. We've got train the trainer programs, where people in hospitals are trained, and then they go back and train others within their hospitals. And so we have strong antimicrobial stewardship programs going. And then the last bit is the investment case and research and development. Again, we have discrete, mostly academic institutions working on new drugs, novel entities for against bacteria, viruses, fungi, and parasites. But South Africa, like other countries, is struggling with dedicated funding for the AMR. And so my next suggestion to the National Department of Health is start thinking about strategically using related funding. And let's draw on existing funding and repurpose it to also answer the AMR challenges in the country. So I did 5 strategic objectives and what progress we've made in that. I think that human health is far more advanced than animal health, and environmental aspects are lagging behind. But that is the norm in high-income countries as well as in low and middle-income countries. So we'll get there. It's just making sure that we are slow and steady and achieve a common goal.
Great, thank you so much. Well, final question based on what we had agreed is your work in looking at the application of vaccines in tackling AMR. Could you share your thoughts on those?
So for every drug that is currently in clinical use, whether it's for humans or animals, there's already resistance to it. Resistance is a normal evolutionary process. So whatever drug we introduce, the time difference may be different, the time lag will be different, but there will be resistance emerging to it. In addition to focusing on developing new drugs with novel mechanisms of action, let's prevent infection. So if you prevent infection, you don't need the antibiotic and you don't create the pressure for the development of resistance. And the 2 ways in which you prevent infection is having really good water sanitation and hygiene services, so clean water, good sanitation, good hygiene. And it becomes a bit difficult and challenging when it comes to our informal settlements, where we don't have necessarily sanitation services or access to clean water. And the second way is to use vaccines. So vaccines will prevent the infection. You won't need the antibiotic and there won't be selection pressure for resistance. There's been a recent report by the World Health Organization in conjunction with IVI in South Korea and the London School of Hygiene and Tropical Medicine, where they did some modeling. And they said that if we could vaccinate vulnerable groups, we would save 500,000 lives and several million disability-adjusted life years. And if we make this a life course vaccination, including adults and children, then we would be saving millions of lives and hundreds of millions of disability-adjusted life years. So in addition to developing new drugs, we should also focus on preventing infection. And there's been lots of correlation between just improving water sanitation and hygiene will make a big difference in AMR. And according to another report by the WHO, it said it takes 60 US cents per capita to ensure that every healthcare facility has clean running water. And if you have clean running water, that's half your battle won. So prevention is better than cure in some instances.
Absolutely, yes. And finally, what are some of the lessons from South Africa or any other countries that you've supported in tackling AMR at the community level? Seeing as in our context, most people access care at that level anyway.
Yeah. we haven't done as much at the community level as we have done at the hospital level. It's easier to work within healthcare facilities than it is to work within the communities. So what has been important is to create an awareness and understanding of antimicrobial resistance at the community level, and to make sure that the people are aware of what antimicrobial resistance is, how important it is to use antimicrobials correctly, and how to not misuse them. We also have the problem of substandard and falsified medications, and antimicrobials are very highly reported in that kind of aspect. So we also need to make sure that we have quality antimicrobials, and that there is regulation and enforcement to prevent the substandard ones being proliferating in the countries. So we are seeing more and more emphasis on antimicrobial stewardship in primary healthcare. There are models that are being created, and awareness and understanding becomes really important in that aspect as well. So we're working with primary healthcare workers, we're working with community healthcare workers, we're working with people within the communities to be able to raise awareness and move this forward. I think antimicrobial resistance is quite a difficult concept, but if we think about antibiotics as the medicine that we've all taken many, many times in our lives, and that these are no longer going to work or are losing their efficacy, we need to ensure that people understand we have to make sure that these medicines are going to be available for our children and our grandchildren in the future. And so we really need to take care, extra special care of them going forward.
Thank you so much. That's our call to action at Nigeria Health for Children.